So I'd like to thank Roberto and the organizers for the honor and privilege of being here this morning. And I'm going to be giving you 3 lectures this morning. And the first one has to do with strategies to optimize nutrition in very low birth weight infants. I'd like to start with showing you a picture of a very low birth weight infant who is 27 weeks gestational age. And the question that we have is, how do we optimally nourish this baby? And I'd like to go back in history to when I first started in neonatology in the mid-1970s. A baby like this, we would not try to resuscitate. We would try to provide comfort care for this baby. The baby would be put to the side of the neonatal intensive care unit, be kept warm, and we would allow the baby to die. Now, in 2016, almost all of these babies are surviving. But one of the problems we have with this survival is it is not optimal survival. Many of these babies have significant neurodevelopmental deficits, largely due to the fact that we do not nourish these babies optimally. And I would like, at the end of this lecture, that you understand the fact that the first few days, the first week, is extremely important. And we generally think about the golden hours of resuscitation and respiratory disease. I think we need to also consider the fact that there are golden hours for nutrition of very low birth weight babies. So over the next 45 minutes, I'd like to talk about the nutritional emergency of extremely low birth weight preterm babies. I'd like to talk a little bit about the neurodevelopmental consequences of early undernutrition, and then talk about some of the nutritional strategies of early parenteral and enteral nutrition, and then I would like to talk a little bit about feeding these babies enterally. So let's start with the goals of early nutrition. I think it's very simple. We want to prevent short and long-term morbidities associated with malnutrition. We want to avoid nutrient toxicity. And we also want to attain a growth comparable to that which we see these babies have in utero. So let's start with this picture. And this is something that you've probably seen before. This is the in utero growth curve of a reference fetus at the 50th percentile and at the 10th percentile. If a baby is born prematurely, at 24, 25 weeks gestation, 26, 27 weeks gestation, and 28, 29 weeks gestation, we see these curves here. These babies have extrauterine growth restriction. And this is partially due to the fact that we don't nourish these babies well enough after they are born. So what are some of the things that we do in neonatal intensive care that are not optimal for nutrition of these low birth weight babies? In terms of parenteral nutrition or intravenous nutrition, common practice is that we start amino acids in the first week of life and we advance them very slowly over the first several days. We start lipid infusions in the first week of life, and we also advance them very slowly. And these amino acids and lipids are frequently interrupted or delayed for many reasons that are not based on science. What about our excuses to withhold enteral feeding? Well, we are very afraid of necrotizing enterocolitis. And because of this, many of us are afraid to use the gastrointestinal tract of premature babies. Here are some of the excuses or reasons that we use not to feed babies early. For example, low APGAR scores. They have umbilical artery catheters in place. They have apnea and bradycardia. They're on mechanical ventilation, receiving CPAP, or they're receiving vasoactive drugs. And we also have this concept that babies grow quite well on TPN. But as you will see shortly, that this is not the case. This actually causes many problems. And none of these, I want to repeat, none of these are based on science. These should not be excuses for not feeding babies. Now let me show you some data from 50 neonatal intensive care units in England. And this is what commonly happens in premature babies. Here we see the intake of calories. So we increase calories very slowly in the first week, and then they plateau. But this leads to an energy deficit over this first week. When it comes to protein, we frequently do not provide enough protein to these babies in the first week after birth. And so this leads to a deficit of protein. When you look at preterm babies at various gestational ages, 24, 26, 28 weeks of gestation, and compare them to term babies and babies at 2 months of age, if you look at their lipid stores, this is the amount of fat in their bodies. They have very little fat compared to term babies or babies at 2 months. Just think about this. How long will it take for a baby that has 1.5% lipid, 1.5% body fat, to lose that store of energy? It will take about 1 to 2 days for that baby to lose that store of energy if we do not provide adequate energy for that baby. Here's a brain at 25 weeks gestation and at term. And you can see marked growth and development that occurs during these 15 weeks. And you can just imagine that if we do not provide adequate nutrition, that this process will not develop normally. So let's look at this. What are some of the studies that tell us that we have problems if we don't nourish these babies adequately shortly after birth? This is a study that was done at Brown University in Rhode Island, where they looked at 124 extremely low birth weight infants when they reached 18 months after birth. And they looked at the mental development index of these babies. And here we see the first week amino acid intake. And if these babies had a decrement or increment of 1 gram per kilo per day of amino acid in the first week, this resulted in an increase in MDI, Mental Development Index, IQ, of 8.2 points. Okay? So 1 gram per kilo per day increase in the first week can increase the IQ of a baby by 8.2 points. What about energy? 10 calories per kilo increment in the first week can increase the Mental Development Index, or IQ, by 4.5 points. So protein and energy make a big difference in terms of these babies' subsequent neurodevelopment. This is work that was done by Richard Ehrenkrantz and colleagues at Yale University, and they looked at the data from the neonatal network, the National Institutes of Health neonatal network in the US. And they looked at the amount of weight intake, or weight gain in quartiles. This is the highest weight gain, this is the lowest weight gain, and here we have cerebral palsy. Those babies that gained the greatest amount of weight had the lowest incidence of cerebral palsy. Same thing with neurodevelopmental impairment. The greatest amount of weight gain resulted in the lowest neurodevelopmental impairment. So nourishing these babies is very important for their subsequent neurodevelopmental outcomes. Now, what are the energy requirements for very low birth weight infants? If a baby is being enterally fed just through the gastrointestinal tract, that baby requires about 120 calories per kilogram per day to reach normal growth. If the baby is on TPN, the baby doesn't require quite as many calories because you don't lose as much due to the gastrointestinal digestion absorption processes. And you can attain positive nitrogen balance with TPN with 60 calories per kilo per day and about 2.5 grams per kilo per day of protein. But this is not enough for growth if a baby is on TPN. If you want a baby to grow on TPN, you need to provide at least 80 calories per kilogram per day. What about the amount of protein? This is work from Dr. Eckhart Ziegler, and here we see the amount of protein that is required for babies who are at these weights at the time of birth. And here we can see these babies require between 3 to 4 grams per kilo per day. The larger babies do not require quite as much protein as these very small babies. So it is imperative that we provide these smaller babies higher quantities of protein shortly after birth. There are numerous studies that have been done now looking at the amount of amino acid intake and the safety of increased amino acid intake. This is one of the classic studies that was done by Dr. Patty Thurine and reported in Pediatric Research in 2003. And in this study, they looked at premature babies in the first week after birth, and they compared what happens in terms of protein balance if babies are provided 3 grams per kilo per day or 1 gram per kilo per day of amino acid. And they used 2 different techniques, a nitrogen balance method and an isotope method. And here we see with the nitrogen balance method, you have positive protein balance, very nice positive protein balance with 3 grams per kilo per day, but you're actually in negative protein balance with only 1 gram per kilo per day. Very similar results for using the isotope method. So positive protein balance with 3 grams per kilo per day, not very good with 1 gram per kilo per day. Also in this study, they looked at the glucose levels. In the low amino acid intake, the 1 gram per kilo per day, and the high amino acid intake, the glucose levels were about the same in the bloodstream. But the insulin levels were different. Those babies receiving the high amino acid intake had higher insulin levels in their bloodstream. What does this mean? Well, let's think about this, okay? If you have delayed TPN, if you don't provide enough of the essential amino acids such as leucine, what begins to happen is that you have a decrease in insulin. With a decrease in insulin, you have an increase in glucose. With increase in glucose, you have hyperkalemia. And so babies who are not provided enough amino acids shortly after birth tend to have more hyperglycemia and hyperkalemia. And a reasonable way to prevent hyperglycemia and hyperkalemia right after birth is to provide them with adequate amino acids, 3 to 4 grams per kilo per day right after birth, so that you have an insulin response and so that you do not have breakdown of tissues. In the early 1980s, I went to a conference, and a very famous neonatologist said this: intravenous lipids are poison. I'm not going to say who the neonatologist was, but this was many, many years ago. And I think that that even holds true today, that some intravenous lipids can be poison, but they are also life-saving because they help provide energy. And we are just beginning to learn about the right composition of lipids. So let's talk about lipids a little bit. Let me ask you, how many of you in your neonatal intensive care unit start a preterm baby on 1 gram per kilo per day of intravenous lipid on day 1 after birth? Raise hands. How many of you start with 2 grams per kilo per day? Okay. And how many of you start with 3 grams per kilo per day right after birth? Okay. So nobody starts with lipids. Okay. I can tell you that in most places, most people do not start with 3 grams per kilo per day or even 2 grams per kilo per day. They start very slowly and increase over a period of time. And I want to provide you with some information that suggests that it is perfectly safe to start with 3 grams per kilo per day, and probably beneficial to start with 3 grams per kilo per day. Here's what happens in France, in French neonatal intensive care units, and in about 80 to 90% of the units, sepsis, hemodynamic failure, thrombocytopenia, disseminated intravascular coagulation, and hyperbilirubinemia are considered to be relative or absolute contraindications. There is no scientific evidence to back this up. Let's start with this slide. This is a baby who has essential fatty acid deficiency. And the reason this baby has essential fatty acid deficiency is because this baby had some respiratory distress and had some hyperbilirubinemia. And the old concept is that if a baby has hyperbilirubinemia, we should not be providing intravenous lipids to a baby with hyperbilirubinemia. Well, over the last several years, there are several studies that have been done that really suggest that there is no concern, there should be very little concern about intravenous lipids displacing bilirubin from the albumin molecule, and that might cause kernicterus. This is a very old concept. But we do have a significant concern about essential fatty acid deficiency. If you are not providing enough essential fatty acids, you can start seeing this. This is peeling of the skin. But you can just imagine, if you see this in the skin, what is happening to the brain? What are the essential fatty acids? There are 2 essential fatty acids, linoleic and linolenic acid. One is an omega-6 fatty acid, and the other is an omega-3 fatty acid. These are called essential because the body cannot make these. You have to get these from outside nutritional sources. There's one study that was done many years ago in the 1990s at the University of Wisconsin that was very important for us in this area. The question these investigators raised was, how long does it take for a premature baby who is not receiving lipids to develop essential fatty acid deficiency? Well, they used an index called the Holman index, or triene to tetraene ratio. If you have a triene to tetraene ratio greater than 0.2, this is considered to be essential fatty acid deficiency. So here, I want you to focus on this first column. This is babies who are receiving no intravenous lipids, had some RDS, and were not being fed. Here they were getting no linoleic acid in the first 7 days. Their triene to tetraene ratio on day 1 was 5%, greater than 0.2. On day 3, 15%, greater than 0.2. And on day 7, 80% greater than 0.2. So this is telling us that by day 7, with no lipid intake in sick babies, 80% of them will have essential fatty acid deficiency. This is potentially a major problem. So early provision of lipids is very important to prevent essential fatty acid deficiency. What about energy? Let's go back to the babies whose picture I showed you before, this 1 kilogram baby. And before I said that this baby, if the baby is on TPN, the baby requires 80 calories per kilo per day for growth. If you do a calculation where you are giving the baby 8 milligrams per kilo per minute of glucose, the baby is receiving 39 calories. With amino acids, 3 grams per kilo per day, that baby is receiving 12. So you still need 30 calories for 80 total. And if you do the calculation, that baby needs close to 3 grams per kilo per day of intravenous lipid to be able to have 80 calories per kilo per day, which is the amount required for growth. And this is one of the reasons why it is recommended, why I would recommend to start right away with 3 grams per kilo per day of intravenous lipid. There are several studies now that show that this is safe and effective. And one of the more recent studies comes from the Netherlands, from Dr. Hans van Godover's group. And they compared less aggressive versus a more aggressive amino acid and intravenous lipid approach. And they found that the more aggressive intravenous lipid approach, where you are giving 2 to 3 grams per kilo per day starting on the first day after birth, is totally safe and actually leads to a good tolerance of these intravenous lipids. So at the University of Florida, over the last 10 years, we have continued to develop nutritional guidelines. Roberto Murgas was very much involved with some of the development when he was a fellow. And we've continued to emerge these guidelines. And so at this juncture, the initial intravenous lipids that we want to provide is 3 grams per kilo per day infused over as long as possible, with a maximum of 3.5 grams per kilo per day, and that no more than 50% of the total parenteral calories per day should be from lipids. To avoid this, you titrate down as parenteral nutrition volume decreases. If blood samples become lipemic, we check the triglycerides. We do not check them routinely. We decrease only if the triglyceride level is greater than 400. If IV access is limited, we may need to window lipids around the medication administration or infuse lipids over a duration less than 24 hours. And we discontinue lipids when IV nutrition volume is 40 milliliters per kilo per day, or when enteral feeds reach 80 milliliters per kilo per day, whichever comes first. Now here is a biochemical pathway of long-chain polyunsaturated fatty acid synthesis. And as I mentioned before, we have these 2 essential fatty acids, an omega-6 fatty acid and omega-3 fatty acid. This is linoleic, this is linolenic acid, and the biochemical pathways of these 2 fatty acids are such that you have desaturation and elongation to 20 carbon fatty acids and then up to 22 and 24 carbon fatty acids. And some of these you probably are highly aware of. Here is docosahexaenoic acid, or DHA. Is this important? Well, we are beginning to recognize that DHA is very likely important, especially in preterm babies. What happens to DHA levels after premature birth? If low, do they cause disease? Well, if a baby is in the uterus, a baby is getting lipids from the mother 2.5 to 3 grams per kilo per day, and a considerable quantity of DHA. If that baby is born prematurely, does that baby get DHA? If we are giving intralipid, okay, the most common form of intravenous lipid given in the United States, there is no DHA in intralipid. If we are not feeding the babies enterally, there is no DHA. Or if we are very slowly advancing enteral feedings, these babies are getting very little DHA. So what happens is that even if mothers are taking large quantities of fish oil, you can see an increase in the amount of DHA in the breast milk of these mothers. But if the mother is not feeding the baby, if we are not providing that milk to the baby in sufficient quantities, you still have a lack of DHA. So here are the fatty acids that go into the fetus during pregnancy, and here we see DHA going to the baby at 43 milligrams per kilogram per day. That is how much the fetus is getting in utero. That stops after the baby is born. So what happens is that here we have the metabolizable DHA intake during the first 4 weeks in 40 preterm babies. This is from a study done by Dr. Alexander Lapillon in France. And here we see this increase in the DHA. But this is how much that baby would be getting in utero. That we don't even come close to what the baby would be getting in utero. So this is potentially a problem. This baby that I showed you before would have a DHA deficit of 661 milligrams per kilo by 28 days after birth. Cami Martin at Harvard looked at this and found that if you have babies who are sufficient in DHA, you have a lower incidence of chronic lung disease in babies who are sufficient in DHA compared to babies who are insufficient in DHA. So that actually shows the relationship between disease and sufficiency or insufficiency of DHA. What are some of the alternatives that we have to the intralipid? Well, we have several alternatives, and probably one of the more studied is a lipid emulsion called SMOF, which stands for soybean, medium chain, olive oil, and fish oil. Do you have SMOF available to you in Panama? You have SMOF available to you in Panama. In the U.S., we still don't have it available to us for routine use. The FDA has not allowed this yet, but we are getting much closer. It is now available for adults, but not yet preterm babies. But this happens to be one lipid emulsion that provides DHA early. And this is a study done in Belgium by Dr. Karl Ellegaard, actually showing that this is, suggesting that this is safe, and it may have some slight benefits in terms of prevention of some of the morbidities associated with intravenous lipid, or with intralipid. Okay, now let's get on to some enteral feedings. Here we have this 27-week premature baby with APGARs of 3 and 5. The baby has a UA and UV catheter in place. The baby is on mechanical ventilation and receiving prophylactic indomethacin. Let me ask you, can we feed this baby using the gastrointestinal tract? The baby is 24 hours old. See? No? Yes? No? See? Yeah, okay, see. What are the consequences of not feeding this baby? How do we feed this baby? Well, if we don't put food into the gastrointestinal tract, there are some consequences. You have an increased risk of sepsis. You have mucosal atrophy of the gastrointestinal tract, lack of trophic hormones, more systemic inflammatory disease. I'll show you some of this as we go on here. About 60 years ago, this lady, Dr. Elsie Widdowson in England, did some studies on piglets. And she found that the suckled pig's duodenum gains 42% of its weight in the first 24 hours after birth. If you do not provide this, the gut does not grow. If you only put intravenous feeding into a newborn animal and don't feed the gastrointestinal tract, what happens is that the gut does not grow. You have to give food into the gastrointestinal tract for the gut to grow. This is some other work that was done at Baylor University looking at piglets. And here we see an enteral intake versus parenteral intake. Here is no enteral intake. Here is all enteral intake. And as you increase the enteral intake, you have better gut growth. So you have to put food into the gastrointestinal tract for it to grow. TPN will not do it. So we have this concept of minimal enteral nutrition, where we now have at least 12 studies that show benefit and no increased risk. Going back, again, about 30 years, work that was done in England by Dr. Alan Lucas looked at hormonal surges with putting food into the gastrointestinal tract. Here are 5 different hormones that are produced by the gastrointestinal tract, which are considered to be trophic hormones. In other words, hormones that produce growth. And here we see the levels in the first day after birth. Here we see what happens without feeding. And if you put food into the gastrointestinal tract, you have a surge of these hormones. So again, putting food in the gastrointestinal tract causes a trophic effect, and here we see a hormonal surge. In animals, in piglets, with just enteral nutrition, this is what the liver looks like, very normal. But if you have parenteral nutrition, only TPN, after 7 days, this is what the liver looks like. Very different than this. It looks pale. Microscopically, you see ballooning of the hepatocytes. You see fat staining and glycogen staining. So after only 7 days, you start seeing damage to the liver with TPN alone. You also have breakdown of the mucosal surface without feeding. And this is just a cartoon that shows if you have breakdown of the tight junctions, you have an increased potential for the antigens and also microbes to traverse or to translocate into the subepithelial space. And then you have a very immunoreactive subepithelium that increases the output of pro-inflammatory mediators. Those pro-inflammatory mediators that come from the gut can affect the brain, can affect the lung, can affect the liver. This is gut-derived systemic inflammation, which can be very detrimental, and you can prevent this by feeding. This is a study from Richard Chandler and colleagues that was done in the late 1990s at Baylor University. And the question they asked was, if you place a baby on TPN compared to minimal enteral feeding or priming of the gastrointestinal tract, does this lead to increased or decreased permeability? They used a technique called lactulose-mannitol ratio to measure permeability, and that's what's seen on the y-axis. At that time, it was perfectly okay not to feed babies by the enteral route for 2 weeks after birth. At that time, it was okay to do that. I think we've gotten away from that. But this study showed what happens if you do not put food into the gastrointestinal tract. And this is if you put a little bit of food in the gastrointestinal tract using GI priming. And here we see a greater permeability of the mucosal surface. So more potential for translocation of microorganisms from the gastrointestinal tract into the bloodstream. Is this why we might see more sepsis in babies who have lines in place and who are getting TPN? I think that this actually is a question of a paradigm shift here. We think that most of the sepsis in preterm babies comes from their lines, but this is an alternative explanation, that the fact that they are not being enterally fed also can cause bacterial translocation and sepsis. I'll talk a little bit more about this in my last lecture, but here is what happens if you give total parenteral nutrition in mice. Okay, this is a study from University of Michigan, and these are actually adult mice. And this looks at the types of bacteria in the gastrointestinal tract. And if you feed these adult mice, if you do feed these adult mice, you see a lot of this type of bacteria, a lot of the red. These are firmicute, a lot of gram-positive types of bacteria. These are considered to be the commensal microbes, the good microbes. If you do not feed, you see a lot of these blue microbes. These are called the proteobacteria, a lot of gram-negative microbes in the gastrointestinal tract of these animals. I'll talk a little bit more about this in the necrotizing enterocolitis lecture. This is work that was done just last year by Cami Martin and colleagues at Harvard University. And the title is Late Enteral Feedings Are Associated with Intestinal Inflammation and Adverse Neonatal Outcomes. What this group did was compare babies who were fed early versus late. And by early feeding, this means that these babies were getting enteral feedings in the first 3 days after birth, and late feedings they started feeding after 4 days. And here are some of the adverse outcomes. And you see in the early feeding group, you had considerably less adverse outcomes, NEC, ROP, chronic lung disease, etc., in the early feeding group compared to the late feeding group. And when you look at the pro-inflammatory mediators in the bloodstream of these babies at 2 weeks after birth, in this group, in the late group, you see very high IL-8 levels. These are neutrophil chemoattractants. These are pro-inflammatory mediators. And the hypothesis that this has raised is that early feeding prevents this pro-inflammatory response. Let me ask you, if you keep feeding a baby, if you are giving indomethacin for adductus or for IVH prophylaxis or for blood transfusions, yes, no? Do you stop feedings? Okay, well, for blood transfusions, I'm just going to bring this up very quickly here. The question is, do blood transfusions actually cause necrotizing enterocolitis? I think we're beginning to recognize more and more that blood transfusions themselves do not cause necrotizing enterocolitis. The more recent studies done at Emory and a couple of other places actually suggest that it is not the blood transfusions themselves, but the pre-existing anemia, that these babies were sick in the first place, that causes, that is associated with the necrotizing enterocolitis, not the transfusion itself. So the data that we have on stopping feedings and prevention of necrotizing enterocolitis with blood transfusions is very sparse. What about indomethacin? This is a study that was done by Ron Kleiman and colleagues. Very difficult to do study. This took several years. It was a multi-center study that looked at feedings with indomethacin, without indomethacin, and the development of necrotizing enterocolitis. They found no association with feeding, indomethacin, and necrotizing enterocolitis. So therefore, I think that we have information that suggests that we can continue feedings if we are giving indomethacin for babies, and this does not increase the likelihood of development of necrotizing enterocolitis. So let's go to this next issue here. You are on call at 2 o'clock in the morning, and the nurse reports that this baby who is being fed 2 milliliters of breast milk every 3 hours is having 2 cc gastric residuals. What do you do? Well, you'd sort of like to say that number 3 is what we do, but oftentimes we will just say, oh, stop the feedings and I'll see the baby in the morning, okay? Well, gastric residuals are a real problem. How do we interpret gastric residuals in these preterm babies? Let's think about this a little bit. Have gastric residual evaluations, has this practice ever been shown to decrease necrotizing enterocolitis or decrease any morbidities in preterm babies? I can answer that by telling you no. The evidence is very, very weak, if there's any real evidence at all. Okay? Now, if you are feeding a preterm baby 8 times a day, every 3 hours, and if the nurse is doing gastric residuals, they pull back on the tube, and if the catheter is on the stomach, if the little hole is on the stomach mucosa, the nurse is potentially doing 8 biopsies a day in that preterm baby. Okay? And oftentimes, the gastric juices are pulled out of the baby, and you look at it and you say, oh, this is a little yellow or maybe a little greenish, and it looks yucky. I'm going to throw it away. Well, the baby has worked very hard to try to digest what you have given that baby. There's been acid output, there's been pepsin output by the baby's stomach. And the baby has worked very hard to get that feeding to the point, and the nurse is just throwing it away. So that's a potential problem with gastric aspirates. So a few years ago, Roberto Murgas and I and some of our colleagues did a pilot study looking at checking and not checking gastric residuals. And this was published in Journal of Perinatology in 2014. And you can see here are some of the outcomes, checking gastric residuals or not checking gastric residuals. And for the most part, there's no difference. But here's an interesting signal over here, that the day of life when PN was discontinued is considerably different. And the day of life when central axis are discontinued also looks considerably different. These are about 5 or 6 days of difference. The p-value here is not significant, but this was a pilot study. When we looked at some of the adverse outcomes, liver disease, sepsis, necrotizing enterocolitis, no difference. Again, this was a small study, only 60 babies. This is a study that we have repeated, and we are now at about baby 150 out of 160, and we hope to finish the final study soon, looking at gastric residuals, doing gastric residuals versus not doing gastric residuals. But I hope that within the next 6 months, we'll have the data on this, a randomized controlled study that was adequately powered to look at the benefits of, or the lack of benefits of doing gastric residuals or not. Do you have feeding guidelines in your neonatal intensive care unit? Yes or no? Well, I think every neonatal intensive care unit needs to have feeding guidelines. I showed you some of the guidelines that we have at the University of Florida, and I just want to direct your attention to a couple of articles that were published about 2 years ago in Neo Reviews. I think that what these do is they provide some scientific evidence for providing feeding guidelines in a neonatal intensive care unit, and I think that these are potentially very helpful. We have actually already emerged and evolved from these feeding guidelines over the last couple of years, but I think that these articles are still potentially very helpful. So let me stop here with some take-home messages. Early nutrition immediately after birth in premature babies is important to prevent significant morbidity. Many of the dogmas that have prevented rapid incorporation of early nutrition have either been disproved, not based on fact, or weak. Scientifically based strategies are available, but we still need some more information to further improve nutrition in these infants. Thank you for your attention.